The following podcast is part of a certified educational activity titled Resect and Protect Against Melanoma Recurrence. Are you prepared for the present and future of adjuvant immunotherapy for stage 2 and 3 disease? Access the entire activity and complete the post-test at peerview.com/BJE860. Downloadable slides and practice aids are also available. Find out how much you know about optimal management of melanoma through a simple 3-step process in this self-assessment activity comprising 5 question modules. First, answer the baseline question to evaluate your knowledge and skills. Next, review the supporting evidence shared by Dr. Luke. Finally, answer the question again to demonstrate what you've learned. Each correct answer automatically counts toward post-test completion, which means that getting your CME credit is fast and easy.
Hello. This is Dr. Jason Luke from the University of Pittsburgh Hillman Cancer Center. Welcome to this micro-learning program on adjuvant immunotherapy in resectable melanoma. The goals of this program will be to improve your understanding of survival expectations in stage 2-3 melanoma and evidence supporting the use of adjuvant immunotherapy in this setting, to sharpen your skills for developing treatment plans that include adjuvant immunotherapy in high-risk resected stage 2 melanoma, and to enhance your ability to address practical considerations related to adjuvant therapy, including risk assessment and safety management. We'll achieve these goals through a series of educational modules that will explore these and other topics through a series of questions and short supporting lectures. So let's begin. We've just answered a question about survival in stage 2 melanoma. Let's explore some evidence on survival expectations in stage 2 and 3 disease. So we'll start thinking about 5-year survival rates in melanoma, which are greater than 90%, but survival varies quite dramatically by stage. On the left-hand side of this figure, you see 5-year survival rates across a series of different tumor types, with the most common tumors, of course, being breast and colon cancers, and you see melanoma at the bottom of that list. And across all stages, 94% survival in this date range of 2013 to 2019. And that, of course, is because most patients diagnosed with melanoma are diagnosed with stage 1 disease. And on the right-hand side, you see melanoma-specific survival from the ACCME database across stages of 1, 2, and 3. And you see the 5-year and 10-year survival rates, which, of course, are quite excellent for stage 1 disease at 98% and 95% respectively. But as you proceed into higher stages, you see that these numbers unfortunately start to go down. So that in stage 2, we see 90% and 84% respectively, and then in stage 3, 77 and 69. As we break down then, thinking about stage 3 disease, which of course has the highest risk and worst melanoma-specific survival, we see this breakdown from Gershenwald et al. In the publication for the AJCC, looking on the left-hand side about how the interaction with the T category, or the depth of the melanoma, interacts with the nodal evaluation. And so one thing that's been updated in AJCC 8th edition is that a higher depth of the primary lesion has a similar impact on eventual melanoma-specific survival as nodal involvement. And it's important then to understand that those deep primary lesions are truly very high-risk disease. And you can look for an individual patient where their T category interacts with the N category to think about how that will impact on stage for stage 3A through D. But on the right-hand side, you see the summary of what that eventually means for patients in terms of that 5-year melanoma-specific probability. And you can see that stage 3A has relatively good outcomes with a 5-year MSS of 93%, whereas in stage 3D, which is a very deep primary with bulky nodal disease, you see the 5-year survival there only at 32%. Now, as we think about the risk in these patients, it's important again to emphasize the impact of the primary lesion on outcome. And here what we emphasize is that even in stage 2 disease, we see a population of patients who are at very high risk of recurrence. So this melanoma-specific survival Kaplan-Meier plot, again, outlines stage 3 disease as we just went over. It's important to point out, though, that for stage 2C disease, which would be a primary lesion deeper than 4 millimeters with the presence of ulceration, those patients have equivalent outcomes by annual melanoma-specific survival to stage 3B. And again, emphasizes this point that the primary contributes at least as much risk, if not more, to nodal involvement, at least until you develop very bulky disease. And from a clinical perspective, this can be useful to understand this risk of recurrence, especially in the context of new tools that are now available to our community. One of those is the Melanoma Institute Australia Risk Calculator, which you can find online. The publication is noted here if you want to read the paper, but really you can just Google this and find it. But on the left-hand side, you see the different elements that go into the risk calculator: the age, Breslow depth, sex, ulceration, the presence of tumor-infiltrating lymphocytes, sentinel lymph node evaluation, melanoma subtype, and mitotic rate. And so pulling these factors off of a standard pathology report, you can input them into this and then get a risk calculation for 5-year and 10-year overall survival. And on the right-hand side, you see the Kaplan-Meier plots for overall survival and recurrence-free survival. So again, considering the risks and benefits of adjuvant therapy, this can be a useful tool to help your patients understand whether or not treatment after surgery is within their goals and a priority for them. This is an evaluation of what that tool looks like for the portal where you can find it. And here we have a QR code that can take you directly there, and a visualization in the middle in terms of what this looks like. On the right-hand side, you see data for a patient who had stage 2, so a deep primary lesion, but not nodal involvement. And you can see what the eventual output here in a very user-friendly manner. Let's take a look at the evidence that supports the use of adjuvant anti-PD-1 immunotherapy in stage 2 melanoma. Here you see the study design for Keynote 716, which was a global randomized phase 3 trial that included patients greater than the age of 12 with newly diagnosed but resected high-risk stage 2B or 2C melanoma who had adequate performance status with ECOG 0 or 1. And 976 patients were randomized 1-to-1 to either receive a year of adjuvant pembrolizumab at standard dosing schedule or a matched placebo, and you can see that each of these was given over 17 cycles. Now, this study then went on to have a part 2, which included unblinding of patients with recurrence, so they had the opportunity for re-challenge or crossover, with the primary endpoint being recurrence-free survival per investigator assessment, and key secondary endpoints for distant metastasis-free survival, overall survival, and safety. And these are the 3-year updated data that we published in the Journal of Clinical Oncology now about a year ago. And you can see that pembrolizumab clearly improved recurrence-free survival in both a statistically significant and very clinically meaningful manner. So at a 3-year landmark, you see that 76.2% of patients are still recurrence-free who have received pembrolizumab, whereas the patients in the placebo arm, 63.4%. And you can see the breakdown on the right-hand side in terms of that RFS benefit for pembrolizumab versus placebo in the stage 2B versus stage 2C populations, both emphasizing a significant benefit for patients. In distant metastasis-free survival, we've seen similar outcomes, which would be expected based on our previous experience using anti-PD-1 immunotherapy in the adjuvant setting. But again, to emphasize, at the 36-month or 3-year landmark, 84.4% distant metastasis-free for those receiving pembrolizumab versus 74.7% for those receiving placebo. And on the right-hand side, that breakdown by the stage 2B versus 2C with a benefit in both populations. Now, pembrolizumab is FDA approved in this setting for stage 2 disease, but so is nivolumab. And that's based on the Checkmate 76K clinical trial, which was similar but slightly different than the Keynote 716 study. In this study, the same group of patients with stage 2B and 2C melanoma who were completely resected were randomized, but in this study, 790 patients randomized 2-to-1, with 2/3 of patients receiving nivolumab at standard dosing over the course of a year versus the matched placebo. And then similarly, if patients had recurrence within 3 years, they could then cross over to get nivolumab. And here we had a primary endpoint of investigator-assessed RFS with secondary endpoints that are standard: overall survival, progression-free survival 2, meaning the outcome to the next line of therapy should patients need it, distant metastasis-free survival, safety, and then a host of exploratory endpoints. And the primary endpoint is noted here, again, recurrence-free survival, and the data, as would be expected, look very similar between pembrolizumab and nivolumab. But to emphasize the point here, at a 36-month landmark, you see 71% of patients recurrence-free in the nivolumab arm versus 61% for the matched placebo. That hazard ratio 0.62, very similar, again, between the two trials. And distant metastasis-free survival, again, showing that benefit, 79% versus 74% at 36 months, and a statistically significant and meaningful hazard ratio, 0.72. So when we think about that impact by stage, I emphasized in the pembrolizumab trial, it was clear that both stage 2B and 2C were benefiting, and we see a similar outcome in Checkmate 76K, where without going to all the details, the impact in terms of unstratified hazard ratios very similar at 0.59 versus 0.65. And so if patients believe that adjuvant therapy is a benefit to them, it should be applied in both stage 2B and 2C, at least offered to patients for their consideration. You've been asked to determine next steps for a patient with resected stage 2 melanoma. Let's see what evidence our choices can support for this patient. So here we see a case of a patient with stage 2C melanoma. Richard is a 59-year-old man with well-controlled hypertension. He presents with a T4B ulcerated 4.2 millimeter depth melanoma of the neck. There are no palpable enlarged nodes. He undergoes wide excision and negative sentinel lymph node biopsy evaluation. So stage 2C melanoma is his final diagnosis. It so happens that BRAF testing is undertaken, and this is wild type. So our clinical questions then is he a candidate for adjuvant therapy, and what do current guidelines recommend? So here we overview the current NCCN guidelines for adjuvant management of stage 2 melanoma. And flowing from the left to the right, you can see the patients are diagnosed initially with a clinical stage, as we talked about. So should they be found to have nodal disease, of course, they would jump to stage 3. But say they're not, they undergo wide excision, as this patient did, and if the sentinel lymph node is negative, they then are in the stage 2 population with a deep primary. And on the right-hand side under the adjuvant treatment bubble, you can see that options there can include a clinical trial, if available, observation, which is consideration, as well as intervention with adjuvant therapy, with pembrolizumab or nivolumab both having Category 1 evidence to support their use in this setting. When we look at the impact of adjuvant immunotherapy with anti-PD-1 across different T categories, we can see that recurrence-free survival is improved across all of these. In this forest plot from the Keynote 716 study, we see the breakdown, particularly in the T3B, T4A, and T4B populations, where you can see that in all three, there's an improvement with a significant hazard ratio showing a benefit for patients favoring pembrolizumab. That similarly has an impact on distant metastasis-free survival, where we see that same breakdown by subgroup for DMFS. And so again, across T3B, 4A, and 4B, what we see is that the impact is highest in the deepest primary lesions. So T4A and T4B, of course, having the highest impact. Now for DMFS at the 3-year landmark, we can see there is overlap with one for DMFS in terms of that T3B population. This is likely an issue related to the length of follow-up. We fully expect that over time, that 0.75 will also continue to trend down, similar to what we see with T4A and B, because that's what we've seen in all the other clinical trials of anti-PD-1 immunotherapy previously. When we look at the breakdown from the Checkmate 76K trial of nivolumab, we see a very similar kind of breakdown. So on the left-hand side, you see that T category, again, T3B, then 4A and 4B, with a significant impact on relapse-free survival. And we also see some interesting data around the breakdown by melanoma subtype, as well as the location of the primary lesion, where you can see that the impact for recurrence mitigation is highest in nodular melanomas compared with superficial spreading. And that's consistent with what we already know about the risk characteristics of nodular melanomas being worse than for superficial spreading. And similarly, we see that the outcomes have a greater impact on head and neck and arm primaries, where we know that patients have had, generally speaking, more sun exposure relative to a leg or a trunk. And again, that's in line with what we've known historically about the risks associated with different melanomas, both by subtype and by location of that primary. So where this evidence has led us then for adjuvant therapy in stage 2 melanoma is we have 2 FDA approvals for pembrolizumab and nivolumab. And the approvals are very similar. You see them in the middle column. So adults as well as pediatric patients who are 12 years or older who have stage 2B, 2C, or stage 3 melanoma that is completely resected. The dosing for these medicines is on the right-hand side, which is very standard and consistent with the way they're used essentially in all other aspects of clinical practice. Let's move on and explore some practical issues that arise once this patient starts on treatment. So here we see a case with a patient with stage 2C melanoma, and you'll remember Richard as a 59-year-old man with well-controlled hypertension. As you recall, he had an ulcerated 4.2 millimeter melanoma, or T4B lesion, with no palpable enlarged nodes. Wide excision was performed with a negative sentinel node. So stage 2C overall is his diagnosis, and he decides to initiate adjuvant therapy with pembrolizumab. During the first month of treatment, he experiences grade 1 colitis. So what would your recommendation be for management? So to discuss that, we'll go over what immune-related adverse events have been noted with anti-PD-1 therapy in stage 2 melanoma. And broadly speaking, we would note that the safety profile has been consistent with that observed for pembrolizumab in other settings. On the right-hand side, you see a full breakdown of the adverse event profile for pembrolizumab versus placebo from the Keynote 716 trial. And without belaboring all of it, we'll just touch on some highlights. That immune-mediated adverse events and infusion reactions occurred in 37.9% of patients in the pembrolizumab group, grade 3-4 events being 11%. And that's compared with 9.5% in the placebo group, with grade 3-4 being 1.2%. Similarly, in the Checkmate 76 case study, we have a breakdown between nivolumab and placebo on a right-hand side in terms of the totality of the immune-related adverse events. And as you would expect, this is a very similar profile to what has been previously seen for nivolumab and also with other anti-PD-1 antibodies. So we won't spend a significant amount of time reviewing this, but toxicities such as fatigue, pruritus or rash, and occasionally diarrhea can be common, as well as monitoring for hypothyroidism. So when we think about how do we put this into context for an individual patient, well, of course, there we need a directed discussion with the patient about their goals and what their overall considerations of risk and benefit would be. And so here we have a circle sort of outlining a patient who's in the midst of making their decision and then proceeding with treatment should that be their choice. And so that patient will be supported by the oncologist to make an initial decision about is it appropriate to proceed with treatment, but they need that support from the other partners in the healthcare team, such as a pharmacist dispensing the drug. We don't want to forget about our ongoing multidisciplinary evaluation with our dermatology colleagues, as well as surgeons for any recurrence, oncology nursing, of course, with the patient and family for education and management of any side effects, and especially our collaborating colleagues in other medical disciplines, such as endocrinology, gastroenterology, or rheumatology, depending on should the patient experience a toxicity, and then, of course, our radiology partners to assess whether or not any recurrence is eventually observed. What's the future of adjuvant therapy in stage 2-3 melanoma? Let's explore some new developments, but start with a review of where we are now. Here we show the NCCN guideline recommendations for stage 2 melanoma, and from the clinical stage on the left-hand side, flowing through to adjuvant therapy considerations. So we recommend that all patients, of course, have wide local excision, And it's still standard of care to offer patients sentinel lymph node biopsy should they have high-risk features. If those patients have a positive node, of course, they then shuttle into the stage 3 workup. If they're negative, however, we still note that they do have can have high risk of recurrence depending on the depth of the primary. And therefore, on the right-hand side, that adjuvant treatment bubble can include clinical trial, observation, or Category 1 evidence to support anti-PD-1 immunotherapy with pembrolizumab or nivolumab. And the different considerations in the stage 3 setting are shown here in terms of standard of care options, where on the left-hand side, you can see different breakdown of stage 3 by approval and for different agents. And on the right-hand side, you see the different drugs that have Category 1 evidence that supports their use for stage 3 melanoma. And that, of course, can include anti-PD-1 immunotherapy with nivolumab or pembrolizumab, but importantly also can include BRAF-targeted therapy with dabrafenib and trametinib if the patient is found to have a BRAF mutation. And this is one important consideration around adjuvant therapy to be clarified, which is in stage 2 disease, currently there is no approval or no rationale for testing for BRAF per standard of care. But in stage 3 disease, this would be a standard thing to do for all patients to make sure they have the option of BRAF inhibition should it be relevant to them. So where is this field going in terms of what's next for adjuvant immunotherapy? Well, really, there's probably 3 important things to be aware of over the relatively near term. So one is the development of individualized neoantigen therapy or personalized cancer vaccine combinations. Another is combinations with new checkpoints, such as LAG-3. And a third is consideration around adjuvant therapy as dictated by biomarkers that are developing in the field. Well, so we'll talk about individualized neoantigen therapy first. And so what is that we're referring to? Well, the mRNA 4157 or V940 is a novel investigational mRNA based on personalized cancer vaccine that includes a single synthetic mRNA encoding up to 34 neoantigens. And the process or the mechanism behind this is shown on the left-hand side in the figure, where a mRNA encoding neoantigens from the patient's own tumor that have been bioinformatically predicted to bind to the major histocompatibility complex and therefore be shown on the surface of a melanoma cell have been synthesized and can then be administered to patients as a personalized vaccine. And you see the science on the left as well as the workflow on the right-hand side where we have to get a piece of the tumor and dot one. There's sequencing performed, the DNA and RNA. The mRNA transcripts then can be encoded and then manufactured into a personalized vaccine and administered as an injection to patients. And this whole process takes approximately 6 weeks. And a phase 2 clinical trial has been performed and read out now and published in The Lancet, updated at multiple meetings such as ASCO 2024. And that study was called Keynote 942. And you see the 3-year landmark for this study that randomized patients to either receive pembrolizumab or pembrolizumab plus the mRNA individualized neoantigen therapy or cancer vaccine. And we see this delta at 30 months of about 19.2%. So a major improvement in terms of recurrence-free survival for patients receiving pembrolizumab plus the INT as compared with pembrolizumab alone. And so this is a very exciting potential development in our field, and a phase 3 clinical trial is now ongoing to evaluate this. Another important element is what about toxicity? And very interestingly, we saw no significant difference in the toxicity spectrum between those patients who received pembrolizumab with the INT V940 as compared to those who received pembrolizumab alone. And you can see here in the table, any grade toxicities as well as serious toxicities, very similar between the two treatment groups. Now, what about biomarker-informed considerations? Here, we'd like to highlight an ongoing phase 3 trial called the NIVO-MELA clinical trial. And in this clinical trial, there's integration of something called a gene expression profile to help stratify patients into different arms of the study. So in this study, patients with stage 2 disease, and you see there on the left-hand side, stage 2A, B, and C, can be randomized into different groups. And this is by whether or not they are deemed to have a high risk of recurrence. And so one group is going to receive nivolumab, and 2 others receive observation stratification based on their risk calculation. And this could be very interesting to tell us, can we really identify which patients are at the highest risk of recurrence, and can we apply a biomarker ahead of time that might decrease the number of patients who have to be exposed to potential side effects of adjuvant immunotherapy. Finally, what about novel checkpoint combinations? All of you will be aware of LAG-3 as the third validated checkpoint for the use in melanoma oncology in the metastatic setting, but adjuvant and perioperative considerations around LAG-3 combinations are also rising in the field. So just to remind people, what is LAG-3? LAG-3 is a regulatory checkpoint that limits the activity of T cells, and LAG-3 and PD-1 can be overexpressed or co-expressed on TILs in melanoma. And it's thought that blocking these two receptors in parallel together can engender greater anti-tumor activity than one alone. And you see on the figure flowing from left to right, in the treatment-naive setting, patients receiving blockade of both receptors with nivolumab and relatlimab potentially can have a greater benefit. And we know from metastatic disease that this leads to better outcomes. So a clinical trial is evaluating this in the adjuvant setting for stage 3 disease, and that study is called the Relativity 098 trial. And in this study, patients greater than the age of 12 who have completely resected stage 3 disease, and you see there 1,050 patients, are randomized 1-to-1 to receive a fixed-dose combination of nivolumab and relatlimab as compared with nivolumab. And this clinical trial is fully accrued, and we're awaiting the final outcome from the study. There's also a second LAG-3 combination, cemiplimab, the anti-PD-1 antibody, with fianlimab, an anti-LAG-3 antibody. And this combination also has exciting data for metastatic disease, so much so that the sponsor has moved forward to an adjuvant study comparing two different doses of cemiplimab plus fianlimab as compared with pembrolizumab in a population of patients including stage 2B, 2C, stage 3, or resected stage 4. And so keep your eye on this space. It seems likely that another combination may be available in the relatively near future. So when we think about where is the field going in terms of the present and future of adjuvant therapy for stage 2 and stage 3 melanoma, we would emphasize the point that adequate risk reduction should be a high priority for patients across this spectrum. Historically, we thought of nodal disease as the highest risk, but as we've already shown you, deep primary melanomas can have just as much risk of recurrence and death from melanoma as stage 3B nodal involved melanoma. So having said that, offering patients access to adjuvant anti-PD-1 should be a priority across stage 2B, 2C, and stage 3 disease. Now, applying those in the most patient-centric way, of course, requires getting their patient's input in terms of their risk calculation and their allowance for the potential for side effects. And finally, this is a space to keep an eye on because there are a lot of novel developments, both with individualized neoantigen therapy or cancer vaccines, new checkpoints like LAG-3, as well as the potential application of biomarkers who might help us hone in on which population of patients are most likely to benefit. So a lot going on, but all good news for patients and risk of reduction of progression to metastatic melanoma. Thank you very much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Merck Co, Incorporated, Rahway, New Jersey, USA. To access all materials for this activity, visit peerview.com/BJE860.